everyone, welcome to Vazyme's webinar. A big thank you to the team for making this event possible. My name is Sitar Lee, and I will be your host throughout the event. Now, before we get started, I want to dip into a few things on how to get the most out of today's webinar. First of all, the webinar is being recorded. The on-demand version will be available after the webinar ended. We will send out email to share the link with you within the next couple of days. So if you enjoy what you see today and you want to share with your peers or colleagues, you're welcome to do so. If you're facing technical issues, please refresh your browser and wait to establish a new connection. You can also send a message to us using the Q&A box. Today's event will run as two parts. First, we are joined by Dr. Ong Choon Kiat, Principal Investigator of Lymphoma Genomic Translational Research Laboratory, National Cancer Center, Singapore. Currently, he also holds an appointment as an Associate Professor at the Duke NUS Medical School. Once the speakers are done for the presentation, we are open for Q&A. So if you have any questions during the event, use the Q&A box on your left-hand side. We'll get to them as many as possible. Now I will hand over my time to our speaker, Dr. Wang, whenever you're ready.
Hi, my name is Choon Kiat, and I'm a Principal Investigator at the National Cancer Center of Singapore. Today, it's my pleasure to share with you some of our genomic work pertaining to the translational study in the T-cell lymphoma that are prevalent in Asia. These are my disclosure. In this presentation, I will give a brief introduction to natural killer T-cell lymphoma and its current treatment. I will also talk about how we make a discovery of the biomarker for immune checkpoint therapy in NKTCL lymphoma and how to improve treatment for this particular aggressive lymphoma. Furthermore, I will also talk about another subtype of lymphoma that is more prevalent in Asia, namely MEITL. And I'll talk about how we, in fact, develop novel therapeutic strategy for MEITL. Lymphoma can be classified into Hodgkin and non-Hodgkin lymphoma. And the non-Hodgkin lymphoma can be further subclassified into the B cell as well as the T cell. T-cell lymphoma can be further separated into the more heterogeneous group of peripheral T-cell lymphoma and the natural killer T-cell lymphoma. The later subgroup of T-cell lymphoma are more prevalent in the east compared to the west. NKTCL lymphoma consists of about 10% of all T-cell lymphoma. And the incidence of this lymphoma could be as high as 30 or even 50% as reported in some part of China. This disease is more prevalent in Asian and as well as in the Native American populations. The disease usually presents itself in the upper area digestive tract, namely the nasal cavity. As shown on the figure on the right, the ulcerative and destructive lesion in fact perforate through the palates of the patients. This disease have a very strong association with EBV infection. And the presence of EBV, in fact, is one of the key diagnostic factors for this disease. This is the pathology of the disease. The tumor is always CD3 epsilon positive and is usually CD56 positive. However, there could be some cases or some negative cases. The tumor expresses cytotoxic molecules and are EBV positive, as I mentioned earlier. In fact, if the tumor do not express cytotoxic molecules or CD56, they will be reclassified as EBV positive peripheral T-cell lymphoma, not otherwise specified. In the past decade, the standard treatment for NKT-cell lymphoma have improved tremendously with the introduction of the L-asparagine-based treatment regime. This regime includes SMILE, PGMOX, GLOX, and some other combinations. And for early stage localized disease, radiotherapy is usually included in the treatment modality. And for patients with disseminated disease, usually only given chemotherapy, and the treatment outcome is pretty dismal, with a 5-year overall survival of less than 50%. And in the recent years, other treatment therapeutics such as the immune checkpoint inhibitors, targeting the PD-1, PD-L1 axis. Histone deacetylase inhibitors and PI3K inhibitors are some of the new arsenal against this disease. Others and ourselves have shown that immune checkpoint blockade therapy is highly effective in relapsed refractory NKTCL lymphoma. As you can see from all this study, not all the patients would respond to this particular treatment. And the ability to identify a biomarker that could stratify these patients would be the holy grail to improve the treatment outcome of this disease. To identify a biomarker of response, we have done a thorough investigation into the clinical, the histological, as well as the genetic of 19 NKTCL patients who were treated with pembrolizumab. On the right, you can see the swimmer plot, where it shows that the patient who have achieved complete response, in fact, have a very durable response to this drug. In this exercise, our whole genome data identified 4 out of 19 sample harboring the PDL1 3' UTR structure rearrangement. This rearrangement includes inversion, tendron duplication, as well as translocation, and all these alterations resulted in the disruption of the 3' UTR gene. And patients whose tumor harbor this particular alteration, in fact, have a much better overall survival compared to those who do not have this alteration. And when we compare to the other clinical factors, the 3' UTR structural rearrangement is the only factors that is significantly associated with better overall survival under the treatments of pembrolizumab. And since PD-L1 expression has been known as a biomarker of response to immune checkpoint therapy, we investigated the expression of PD-L1 using IHC in our samples. And to our surprise, we did not see any significant association between the PD-L1 expression and its response to immune checkpoint therapy. Next, we perform a prospective screening of patients that come into the clinic. So this is a 70-year-old gentleman who achieved complete response after 6 cycles of GLOX. And unfortunately, he has a relapse after 1.5 years. And when we sequence the tumor, we have identified a tendron duplications at the 3' UTR of his PDL1 gene. And as expected, when he was given pembrolizumab, he achieved complete response and currently is still undergo complete remission. And below is just a PET CT scan showing that he responds well to the pembrolizumab treatment. This exceptionally good response in a patient with tumor harboring the PDL1 structural rearrangement is not unique to NKTCL lymphoma. In fact, in this case report, exceptional response to pembrolizumab has been reported in ovarian cancer, whose patient also harbor this particular alteration, suggesting that this alteration is in fact a good biomarker of response for immune checkpoint therapy. To bring this discovery to our patients, we co-developed assays to detect the PD-L1 structural rearrangement with Lucent Diagnostic. Lucent Diagnostic is a homegrown diagnostic company who has a presence in Singapore, Hong Kong, California, as well as in Suzhou. And if you want to know more about the product, you can Google this particular company. So how common is this alteration in NKTCL lymphoma? We did a targeted sequencing as well as a whole genome sequencing of 206 NKTCL lymphoma and identified that this alteration present in about 38% of the cases. So this suggests that about 40% of these patients might actually respond well to the immune checkpoint therapy due to the presence of this structural alteration. Next, I will talk about how we can improve the treatment of the early stage localized disease for NKTCL lymphoma. As mentioned earlier, this group of lymphoma responds very well to the combination of chemo and radiotherapy. And in fact, this group of patients have a 5-year overall survival of up to 70%. And in order to intervene the treatment modality for this group of patients, we must be able to identify who in this group of patients would do badly to this current treatment modality. To stratify the NKTCL patients with the localized early stage disease, we turn to PINK, which is the prognostic models for NKTCL lymphoma. These models is based on the clinical factors such as the age, stages, the subtypes, as well as the distant node metastases. And none of these factors, in fact, are able to stratify the patients from the early stage localized disease. So we know that cancer are driven by genetic mutations, and the mutations itself have important roles in the progression as well as the metastasis of the disease. In fact, it also play a role in drug response. So others and ourselves have done quite extensive genomic profiling of this particular disease. And we think that some of these somatic mutated genes might have a prognostic value in NKT cell lymphoma. So to identify somatically mutated genes that's associated with the treatment outcome, we have performed genomic profiling of 206 tumor. This tumor come from Singapore, Guangzhou, Taiwan, as well as in Belgium. And in this exercise, we have identified 289 recurrently mutated genes. And further analysis identified 13 genes that is significantly associated with progression-free survival. And about 40% of these 206 samples, in fact, harbor a mutation in one of these 13 genes. As shown here, the 13 genes indeed is significantly associated with poorer progression-free survival as well as overall survival. And this observation is further validated in a separate independent cohort, as earlier published by Xiong et al. This is a correlatogram. It shows that our prognostic gene sets is weakly or no association with the current clinical factors, suggesting that we can potentially integrate these factors into the current prognostic models. As shown here, we have integrated our 13 prognostic gene sets as one of the factors into the current prognostic models. As shown here, the integration of the 13 prognostic gene sets into the current prognostic model significantly improve the power of this model, as demonstrated by the improved Harrell C indexes. And visually, you can see that the progression-free survival curve in fact separate even better. And so is the overall survival, as shown. So the improved prognostic models can be effectively used to monitor of relapsed disease. And importantly, these 13 prognostic gene set could effectively stratify patients who are in the early stage localized disease treated with the current standard treatment therapy. So suggesting that this group of patients that would do worse can be effectively stratified for better management of the disease. So overall, I have talked about treatment for NKTCL for the early stage disease and how we can improve by making use of our prognostic models and as well as the prognostic gene sets. And for the relapsed refractory disease or the advanced stage disease, I've talked about biomarkers of PD-L1 structural alterations. And in fact, there are many other potential biomarker and therapeutic strategy for this particular disease, which I think the audience can further explore on your own. So the next part of the talk, I will talk about our therapeutic insight into this particular subtype of aggressive lymphoma called the Monomorphic Epitheliotropic Intestinal T cell lymphoma, or in short, we call it MEITL. Maybe I will give a brief history of this particular subtype of lymphoma, called enteropathy associated T cell lymphoma, or in short, EITL. So EITL consists of about 5% of all T cell lymphoma, which is even rarer than the subtype that I have just mentioned to you earlier. And this particular subtype of lymphoma can be further classified into the type 1 and the type 2 disease. Type 1 is associated with celiac disease, and it is predominantly in the Western population, while the type 2 is not associated with celiac disease and is predominantly in the Eastern populations. And of course, pathologists from Asia the pathologists recognize these two particular subtypes. And Professor Tan Soo-yong from Singapore, in fact, named this particular subtype of type 2 disease as epitheliotropic intestinal T-cell lymphoma, or EITL, as the disease show prominent epitheliotropisms without celiac disease. However, Professor John Chan from China, from Hong Kong, named this as a monomorphic intestinal T-cell lymphoma, or MITL, mainly because of the morphologically more monomorphic looking small to medium cell. And in the 2017 WHO classification, this particular subtype disease is renamed as a monomorphic epitheliotropic intestinal T-cell lymphoma, or what I mentioned earlier, called MEITL. So MEITL is a rare aggressive subtype of intestinal T-cell lymphoma, as presented here as lesions in the small intestine. The disease is separated into three zones. Away from the tumor is the distant mucosa, and you can still see that there's a normal-looking IELs with intact brush borders, as well as the global cell. However, moving towards the tumor, you can see the more neoplastic looking cell, and towards the tumor, in fact, all the cells look pretty neoplastic. And this disease is positive for CD56, CD8 alpha, as well as express cytotoxic granules. However, different from NKTCL, this disease is EBV negative, or EBV negative. Clinically, the patient will present with abdominal pain, bowel perforation, weight loss, and diarrhea. And there's no standard treatment. In fact, patient will just treated with chemotherapy, with or without surgery, and if possible, stem cell transplant. And because the disease is very aggressive, the overall survival is very poor, with a median overall survival of only 7 months. And currently, there's no treatment modality or treatment therapy, standard treatment therapy or targeted therapy for. So we did a whole exome sequencing of 4 cases, and interestingly, to my surprise, I have sequenced many tumors and many types of tumor, and surprisingly, these 4 tumors allow me to identify 14 recurrently mutated gene, which is pretty rare. And interestingly, if you look at it, they are grouped into various pathways. The majority of the alteration is in the JAK-STAT pathway, as well, where you can look at mutation. There's there's JAK3 and the STAT5B mutation, and also targeting the histone modifiers itself, such as SETD2, CREBBP, and AXSL3. So suggesting that the histone modification is an important aspect of this alteration, is an important aspect of this disease. And also mutation in the GNAI2, which is a G protein coupled receptors that play a role in the MEK pathway. So this is an activating mutation, and this is the prevalence of these alterations as we previously sequenced. So next, to determine if the altered oncogenic pathways are targetable, we perform a drug treatments on the this ex vivo cell culture from the MEITL patients. And here we can see that the cell growth is inhibited by the JAK-STAT inhibitor, as well as MEK inhibitor, in a dose-dependent manner, while the control cell treated with gefitinib have no response, suggesting that this cytotoxic activity is specific. And this is also further validated with Western blot, showing the downregulation of the downstream signal for these two pathways. And a few months after our work, Professor Liver Lawrence from the French group also shows that SETD2, CREBBP, STAT5B, JAK3, these are the commonly and frequently mutated gene in this particular subgroup of lymphoma, which is similar to what we have. And the other group from the NIH also shows that the JAK-STAT and the RAS signaling pathway is activated in this subgroup of lymphoma. However, because this is done with a targeted panel, so it did not actually report about the SETD2 alteration. And 1 year after our work, Professor Sandeep Dev from Duke University also reported a similar finding, but they have done a more extensive characterization of the functional loss of SETD2. So with all this study, in summary, we see that the JAK-STAT pathway and the MEK pathway is a potential target for this lymphoma, and other potential target the CREBBP mutation as well as the SETD2 mutations. In order to develop treatment modality against this particular lymphoma called the MEITL, you need some model system to work with. So we are fortunate to establish most probably one of the world first these xenograft models for this particular subtype of lymphoma. And we shows that at Passage 3 as far as even Passage 6, the morphology of this or the histomorphology of this lymphoma is still quite consistent, roughly consistent, as well as we can still preserve the key mutated gene in this in the xenograft. And in order to find the best combination treatment for this disease, we harness the quadratic phenotypic optimization platform, or in short, QPOP. This is a platform that is designed by Professor Edward Chow, and this is done in collaboration with Professor Chow Group. So what is QPOP? QPOP relies on the ideas that any complex system robust enough can be accurately mapped through specific regression analysis. And the system based on an intelligent design experiments to minimize the number of test combinations needed to accurately map the entire drug combination space from a set of drugs. So what it means is that, for example, 14 drugs, if you look at two level combination, in QPOC, you only need about 128 experimental data point, compared to if you do a high throughput screening using just 14 drugs in two combination, you will need about 16,000 data points. So QPOC is a fast and cost-effective method for drug combination design and evaluation. So what we do is that we can use either the patient ex vivo cell or xenograft ex vivo cell. Basically, you dissociate the cell, you plate them into a 385 plate, and treat them with a designated combination of 14 drugs or 12 drugs. And eventually, after 48 or 72 hours, you do a readout using a cell death assay. Or and this information will be fed into the system, and the QPOC will eventually predict out which are the drugs that come in synergistic or antagonistic combinations. And this system we have applied it to, in fact, to patients. This is our first index patients, showing that this is a patient who has a hepatosplenic T-cell lymphoma, has failed 6 lines of treatment. And the QPOP predicted the best efficacy using pembrolizumab and bortezomib. And in fact, this patient achieved a complete response with this combination treatment. And more recently, we expand our clinical study to 75 samples from 71 patients in the relapsed refractory non-Hodgkin lymphoma setting. And this exercise is in fact to test out the feasibility of a QPOP-based clinician decision support. And what is interesting in this study is that we have 17 of the patient, in fact, adopted the off-label use of this particular QPOP predictions. And of this, excitingly, 5 of them achieved complete response, which is quite exciting and impressive. So using that system, we applied to our MEITL xenograft models with 12 drug combinations, and the system predicted P-Mozyme, which is a STAT5 inhibitors, and romidepsin, which is a HDAC inhibitors, to be the effective combinations. And here we shows that this synergism is achieved only when the two drug combine, and it also reflected in our MEITL PDX model. So in summary, we have identified PD-L1 triple UTR structure rearrangement as a biomarker response to the PD-1 blockade therapy in NKTCL lymphoma. And I have also shown that how we have improved the prognostic models using DNA sequencing technology, as well as to identify subgroup of patients who would do badly at the early stage localized disease setting, which could further improve the treatment outcome of this group of patients. And I have also identified the oncogenic pathway in MEITL, which help in the design and development of a normal combination treatment using the QPOP system. And with that, I would like to thank my collaborators and funding. Too many to name, but it really take a whole village to get this work done. And with that, I thank you and happy to take questions. Okay. Is there any questions that
Prof. Wang, we do have a
yes.
few questions for today's topic.
Yes.
So the one is, besides NKTCL, any other cancers also harbor the PD-L1 3' UTR structural rearrangement? And does immune checkpoint blockade therapy work on them?
Yeah. As for I think other than NKT cell lymphoma, which in fact harbor a frequent alteration in this PD-L1 structure 3' PD-L1 structure rearrangement. The other subtype of lymphoma that has these particular alterations is the ATL, adult T cell leukemia or lymphoma. This particular subtype of lymphoma is in fact very unique in the sense that it only usually occurs in the Japanese populations. And in fact is associated with another virus that's called the HTLV1 virus. And however, this particular lymphoma, because of the recent, what happened is that although this alteration is present in this particular lymphoma, there is a failed trial. In fact, there's a Novel trial that is started on this particular lymphoma, and 3 of the patients recruited, in fact, have what they call it, a hyperprogression. So in that kind of setting, although these 3 patients have not been sequenced extensively, so basically they just do a 13 gene, I think, sequencing. Although this particular these 3 patients have not sequenced or have not verified that the PD-L1 structure alteration indeed is it present in this patient, but they have hyperprogression, and in fact the whole trial was actually stopped. Whether to address how about the patient with PD-L1 structure alteration in this particular lymphoma, will it work? I don't know. This one, I don't think anybody would dare to start a trial on this particular subtype of lymphoma. Yeah.
Okay. So we have another question. So are you going to do a prospective trial with the prognostic gene set on early stage localized NKTCL? And what are you going to do with these patients who are going to do worse?
We would like to do a trial on this particular group of patients. So this early stage NKTCL patients. But however, because as you know, this NKTCL lymphoma patient, in terms of the numbers of patients in Singapore, is pretty small, I would say. And we hope that maybe our colleagues in China will be interested, because definitely in terms of the numbers, they have the numbers to conduct a prospective trial on this. And as for the patients that if let's say we identify a particular patient who would do worse for the standard therapy, we can actually treat the patient more aggressively, in the sense that we can maybe give more aggressive therapy like the PD-L1 inhibitors, which has been shown to be effective in this lymphoma. Yeah.
Oh, okay. We have a last question for you. So, are we ready to treat all MEITL patients with I'm not sure how to pronounce this.
The meter.
Yeah, this is a bit hard for me to pronounce it.
Yeah.
Yeah, this I'm pretty sure it's not English. Romidepsin and pembrolizumab. Is that
I think in our study we shows that it works in our xenograft model, number one, and the second thing is that this is just a single case. Definitely we hope that we can do more cases to ensure that this particular combination is sort of like common to or commonly effective to all meter. But meter is even rarer. If you look at my presentation slide, if NKTCL is like 10% of all T cell lymphoma, meter is like less than even 5%. So this particular subtype of lymphoma, if currently there's no standard treatment. So I think if I have a patient, I would try. But however, must take note that this is an off-label use of the combination, and must be also aware that romidepsin and pembrolizumab, there is some drug contraindication, so it has to be treated carefully, and the patient has to be inpatient. Yeah.
Okay. I think that's all the question I have for you today. And
is there any other question?
Okay. Let me take a look at the audience actions. I see there's some people who are missing out on the PPT slides. Okay, so who is raising the hand right now?
Yeah.
Can you see who's raising the hand right now?
I'm not too sure. Doodle? Not sure who is Doodle.
Because I cannot see from my would you like to answer his questions?
If he's asking.
Okay.
Yeah.
For those who are like I know there's a few people who are from the audience. You guys have missed out some information on PPT slides. Just so you know, this webinar is being recorded, and the on-demand link will be available after this webinar end, and we will send out emails to share the link with you guys probably within the next 24 hours. So no worries about like missing out on the information on the PPT slides. So yeah, I guess
and feel free to contact me. My email information is there. If you want to clarify certain things, and if you're interested in the disease itself, do write to me. Yeah.
Okay. I think this is all the time we have today, and I'm pretty sure you're very late on your end as well, because it's 23, almost 12 right now. And
yes.
You have a good night, and I hope to see you guys very, very soon for our next event. Okay, thank you, everybody. Thank you.
Okay, thank you. Good night.
Goodbye.
Bye.